morning. Thank you very much. Thanks, colleagues. So this morning, I've been tasked with defending the position of doing single session bilateral retrograde intrarenal surgery to do both kidneys using one anesthetic and in one sitting. So before I say a word in favor of the stance, I first just want to be clear about what I'm defending, because I'm not here to argue that bilateral intrarenal or bilateral retrograde intrarenal surgery is for all patients with bilateral stones, because that wouldn't be defensible. But rather, I'm going to defend it for a specific patient which has been set out for us today. And I'm going to show you that staging is not a cautious choice, but rather it's a second avoidable surgery that's often dressed up as caution. So I just want to remind all of the patient that we're talking about. And we're talking about a fit adult, ASA 1 to 2, with normal renal function, normal pelvic calloceal anatomy, sterile preoperative urine, bilateral 10 millimeter mid-pole stones, and consequently probably a burden under 25 millimeters in total. Now, I'm going to start off by saying, first and foremost, that when you look at the literature, for every risk in bilateral retrograde intrarenal surgery, the risks are either absent in this patient or they're entirely avoidable. The sepsis predictors, the renal dysfunction predictors, and the reasons that older textbooks told us to do staged procedures is switched off in this patient, or you can mitigate it. So the question then becomes not, is it safe to do bilateral retrograde intrarenal surgery, or rather, is it dangerous? It can be dangerous in the incorrect patient, but the question is narrower and far more honest. And that is, can we justify doing two operations in this patient? And I'm going to show you by the guidelines, by the efficacy data, and by the safety data that the answer is no. This is the textbook ideal candidate for same session treatment. So let me prove it to you. I've got 5 claims that I want to make, and I'm going to set out to just run through them. And the first one is that major guidelines endorse or allow you to proceed with single session bilateral retrograde intrarenal surgery. The efficacy is equivalent, and you lose nothing on stone clearance by doing it in one stop. The catastrophes that will definitely be raised here today, everyone has a built-in mitigation over and above the fact that it's pretty rare. And then fourth, although there are genuine weak points, I'm going to concede them, but I'm also going to show you how one can control them. And finally, I'm going to show you what's probably most important for us, how it saves anesthetic, how it saves theatre time, and how it saves money. And this is probably the most pertinent factor in the South African setting. So, my opinion is one thing, but why don't we consider the guidelines? Because over the last couple of years, that's where the debate has quietly shifted. So you can read this with me. This is the AUA statement for this year, 2026, on bilateral retrograde intrarenal surgery. And they say that clinicians may offer bilateral same session stone treatment. It's a conditional recommendation, and the evidence is grade B. Sure, great. I'm sure people will seize the opportunity to say the word is conditional, and I'm going to grant it. It is conditional, but it's a permission, maybe not a mandate. And what you'll actually notice is that compared to previous guidelines of previous years, that default posture has changed. It's gone from always staging these cases to there are some patients that are probably suited for this, which means that the data is shifting. The second statement from the AUA guideline is that clinicians should place a urethral stent if you're doing bilateral surgery or you've got a single kidney. And that probably mitigates the biggest argument that's going to be against bilateral surgery, which is the risk of causing sepsis or obstruction in both kidneys at the same time. So the safety net is built in. And then finally, our own guideline that we use most often, the EUA guideline of 2026, states that you should individualize it, stone size, number, location, and anatomy, but it does not prohibit same session bilateral treatment. So before we look at a single outcome, the position is this: two procedures is fine, but the guidelines say that you can do one. I guess we still want to see, does it work though? So the claim I'm going to make here is simple and it's strong in that you don't sacrifice stone clearance if you do it in a single setting. And I've got 2 meta-analyses to deal with this. So both of these come from 2025. The first one is from Andrade, and they look at 836,000 patients across 13 studies. And what essentially they saw is that when looking at stone-free rates in single setting versus staged, you've got a relative risk of 0.89, but the p-value equals 0.23, so there's no significant difference. The second one is another meta-analysis from 2025, And this one specifically looked at single setting, 1,218 patients. Once again, here, they say that the stone-free rate is 0.73. But here, your confidence interval goes from 0.43 to 1.23, crossing 1. And so once again, it's not statistically significant that there is a difference in stone-free rates. So whatever else can be argued today, we cannot say that you clear fewer stones if you do a single setting surgery, because the highest level of evidence, meta-analyses, two of them, 2025, show that you have equivalence in the ability to get stone clearance. Now, you might reasonably ask, that's all good and well, but how does it compare head to head if you took single setting or you took a staged procedure? And I've got a study for you that addresses that. This is the only one that I could find, which is a direct or study that puts directly single session retrograde intrarenal surgery versus staged. And this is by Fiscus and colleagues. And what they found when they looked at 63 single sessions versus 37 stage patients is that there's no difference in stone-free rates and there's no difference in the need for additional procedures. And they had a comparable stone burden in both studies, so 30.9 and 32.4. And then the number that becomes the cornerstone of this is operative time. 86 minutes if you do it in a single setting versus 139 minutes in total if you do it in two. So staging a procedure is not a more gentle way to deal with the stone. It's a longer, and I'm going to show you later that it's a more expensive option. The author's own conclusions in the study was that it would strongly consider single setting bilateral surgery in the correct patient. So I've shown you the guidelines and I've shown you meta-analyses that show you stone-free rates. And we've now noted that the operative time is also reduced. But maybe you want real world data. So I'm going to show you two studies here. We've got on the left a study by Castellani, and this is the largest series ever looking at bilateral surgery. It's 1,250 patients. But what's interesting about this cohort is the median stone size is 10 millimeters, which is our patient that we're considering 1,250 times over. All right. And what they found is that bilateral stone-free rates is 73%, median surgical time, 75 minutes, and the need to stop early and abandon procedure only occurred in 6.8% of patients. But I think this is also important to note is although it's rare to stop early, you also always have that safety net that you can stop early. A more contemporary study and more relevant to the technology that we have available is on the right. And that's the modern FANS suction sheath registry from 2025. This is a flexible and navigable access sheath or suction access sheath surgery. And what's interesting about it is it's held to a deliberately harsh standard where they look at non-contrasted CT at 30 days. And you'd notice that if you look at a lot of these studies, they often use ultrasound. But even with that, 75.7% of patients, so more than 3/4 of patients, had at least one stone or one kidney cleared of all stone in a single setting. And your reintervention rate was 2.6%. And you cleared bilateral or bilateral zero fragments was 42%. So the highest level evidence says it's equivalent. The only head-to-head says it's equivalent and faster. And the largest real-world series in outpatient says it works. So I think this closes the discussion on efficacy, and there's clear evidence that it has efficacy. But probably the heart of the matter is safety, that most people will argue. And this is the crux of the entire debate. The word that's often raised here is catastrophe, because if you block two kidneys, you get sepsis from two kidneys, then you potentially have what we call double jeopardy. It's a powerful narrative, but I'm going to show you through the data that's probably also a myth. So the cleanest refutation of double jeopardy in the narrative literature is from that FANS prospective registry that I showed you. 115 patients, all of them underwent same setting bilateral retrograde surgery. Cases of sepsis, 0. Transfusions, 0. It's not low, it's not acceptable, it's 0 in a prospective multi-center study. The other information that we also gleaned from that study is the ureteric injury rate, 1.7%. And of those that were injured, it was all grade 1 trachea injuries. No pelvic calloceal injury. The mean pain score was 1.7 out of 10, and 4.3% needed readmission. So when they tell you that operating on both kidneys courts bilateral sepsis. I want you to remember this slide because this clearly shows that perhaps is not true, and especially so in the contemporary surgery where we have suction access sheets available. So this is only 115 patients. Perhaps that's small. We can scale it up by 10. We can go back to Castellani's data, which was the 1,250 patients. Out of their side effects that they had, transient fever, 10.7%, sepsis, 2%, transfusion rate, 1.3%, stopped early, 6.8%, and median minutes, 75 minutes a year. So let's look at that sepsis. What's interesting about the sepsis component is that it identified independent risk factors for sepsis. And more over and above that is I want us to compare those risk factors on the background of our patient. You had a 5.99 or six times increase in sepsis if you had no antibiotic prophylaxis. I'm not sure who does surgery without antibiotic prophylaxis, but that is definitely a controllable or mitigatable factor. Kidney anomalies. As mentioned, we're not talking about a patient who has an abnormality in their function or anatomy of their system. So that is also something that is controllable. And then operative time, more than 100 minutes. If you think back to this large series, they're all operating at a median time of 80 and a median time of 75 minutes. That's all mitigatable. The only one that perhaps is not mitigatable is female sex. So later on, I'm sure it's going to be mentioned about the GRAND study, and they're going to bring up sepsis. And I want you to remember this slide, which shows that, yes, you can get sepsis. 2% out of 1,250 patients is not only manageable, but the independent risk factors are also controllable. So I want to show you one more safety number. Whatever they say today, they're going to say that the complication rates are higher in bilateral surgery. Okay. And that's true, but one has to discern what is a minor complication versus a major complication. In 836,000 patients in this meta-analysis, severe complications being Clavian Dindo 3 or higher was actually very low. They had a 1.22 relative risk with a p-value of 0.53. So it wasn't significant. And this shows you that there's no increase in the risk of significant side effects or severe complications, but rather minor. So the complications that end up getting reoperated or end up in ICU, that's flat or equivalent. There's no difference. But rather, I'm going to concede that the weakness is probably that there's an increase in minor complications, a bit of scratching on the ureter, hematuria, need for analgesia. Now, it's probably wrong to say that there's no weak points to bilateral surgery, and I think it's worth looking at them quickly because I can show you that I think that they're all controllable. So, as mentioned, we have to concede there's more complications with bilateral surgery, more minor events, Clavian 1 to 2 events, more retreatment. And there's a study by Danilovic which looked at your overall risk of complications, and they showed that it was 40% versus 16%, so much higher in bilateral surgery. But you have to nitpick this a bit. The data is dominated by Clavian 1 and 2 problems, and that skews it. Severe complications, as mentioned, statistically insignificant. It's not increased. And then one has to consider the data that they're looking at. Most of the data that come out is a bit biased because you're considering 2 renal units versus a single renal unit. Just by virtue of what you're covering, you're obviously going to have more Clavian or complications related to 2 units. And one of the only studies that actually considered per renal unit complication showed no difference in complication rate. And I think that's an important thing to understand. So just because you have a higher risk of having minor complications is not a reason to subject the patient to a second surgery. What about the renal function? And I think this is interesting data. What about the renal function dip? So the question is, you're stressing both kidneys at the same time. What about the renal function? And I think it's a fair question. And once again, reflecting on Danilovic's group, they answered this question directly by following the trajectory. And what they found is that when you compare baseline to postoperative immediate and postoperative day 3, there is a difference and the renal function dips. All right. And if we stopped examining at that point, perhaps an opposing argument would have grounds here. But if you go on to examine this at postoperative day 10 and postoperative day 30, the statistical significance, there's no statistical significance. It's statistically insignificant. This shows you that the dip in renal function is transient. It's just a little bit of a dip. It's not that the patient falls off the cliff. And I think this is an important concept to consider that yes, you're going to have a dip by post-operative day 3 if you started at a normal baseline, but that will improve by day 10 to 30. So the safeguard here in the data is to keep your operative time under 120 minutes. Everything so far discussed has probably been about the patient, but I think an important consideration here is what about the system? Because patients are treated in a system, and here in South Africa, with our limited resources, this is an important concept. If you look at the maths, it makes sense. If you're doing a single operation versus 2 operations, every time you need 2 anesthetics for a patient, and you put this patient at risk twice, airway events, cardiovascular instability, post-operative nausea and vomiting. And if you've got an elderly patient, they can get delirium or cognitive dysfunction. And that's purely based on exposure. Every time they have an operation, you roll that dice and you can get one of those. So one anesthetic is actually a safety measure. It means the patient has one induction, they have to emerge once from that, and they have to have one recovery. The frailer patient, in fact, may well benefit from having a single procedure. There's a few resource wins that I also want to look at, and it's 3 in total. We've mentioned this operative time. You operate for shorter if you do it in one sitting. This is an interesting one, and it's that you use significantly less disposable devices. And especially in our contemporary practice, there are more disposable scopes, more disposable access sheets, and you definitely decrease the amount that you use. Hospital stay. Now, you would think to yourself that you were operating on a person and you're doing it in one setting and you caused sepsis, if you thought that way, or you caused the problem that they would stay longer in hospital. But it's actually been statistically proven that the hospital stay is similar, which means that if you're saving cost on equipment, you're operating less for a shorter time on the patient, and the patient stays an equivalent amount of time as someone who had 2 surgeries, you're effectively saving money. So let's make it local. If you have a patient that comes for an operation and they have to come twice, that's 2 hospital admissions. That's 2 theater slots they're going to occupy. That's twice that they're going to be off from work for X number of days. And if this patient, if you're servicing a population like out in the garden route or wherever, this patient is coming twice back, yeah, and back for the operation. So I think it's an important thing to think about in the background of a constrained public service. And this shifts the argument then out of the efficacy and safety sort of domain to thinking about equity, and that this probably provides more patients with care and allows you to operate on more patients. So this is not a license for recklessness. I can't say that you can operate bilateral kidneys, same setting for every patient. But I do think that there's some caveats of how you can do it. And that's firstly to select the right patient. Fit patient, normal renal function, normal anatomy, sterile urine, burden of disease under 25 millimeters. And then I think if you go through these steps, you treat the easier side first. And if you have to bail, you bail. That means you can clear one statistically. Mandatory ureteric stenting. The AUA endorses it, and that's going to help protect you against bilateral obstruction, bilateral sepsis. Suction sheaths. If you have that available, we know that lowering that intrarenal pressure will prevent infection. And that's sort of the biggest thing we're worrying about, yeah? And then capping your operative time and saying that the ceiling is less than 120 minutes. That's also going to reduce a lot of the side effects. And then, as mentioned, they've only needed to abandon procedures in 6.8%, but you've always got that fail safe. You can do one. If you run into trouble, you can abandon the procedure. So those are my thoughts, and those are the reasons that I think one should do bilateral retrograde intrarenal surgery in this patient. Thanks. Yeah, so just very briefly, thank you very much. I appreciated all those insights as well. So I just want to touch on 2 things, and that's the catastrophe narrative and the grand study, which I probably didn't go through. So I just want to run through everything and sort of a rebuttal. Bilateral sepsis is catastrophic. We saw in the FAN study, 0 out of 115. And when they looked at 1,250 patients, 2%. And we saw that all of that 2% had 3/4 of that were modifiable independent risk factors. Bilateral obstruction, AUA is telling us, put in stents if you're going to do bilateral one-stage surgery. Bilateral ureteric injury, 1.7%, grade 1 only, no high-grade injury. And in fact, the data on long-term is no increased strictures. Risking both kidneys at once, I think I demonstrated. You're going to drop your renal function on day 3. It's going to climb back up to normal, day 10, day 30. The headlines. So the biggest study that's against single stage is this. It's called the GRAND study from Pagides. And if I looked at this, it would be horrifying. Sepsis, acute kidney disease, transfusion, ICU admission, in hospital, mortality. But the devil's in the details. Firstly, it's an administrative database. Once again, you're comparing two renal units to a single renal unit. We don't know stone size. Bilateral patients had worse baseline characteristics. This makes sense. Who do you want to get through a single surgery? It's that patient that you dare not take back again. So in this database, the most sickly patients got single setting surgery. That confounds your data. Were they sick and had poorer outcomes because of their comorbidities or because they had bilateral one-stop surgery? And then finally, there was a published rebuttal letter on the SCRAN study that also mentioned these factors. So database association does not mean causation. Yes, who should get stage surgery? Abnormal renal function, you got one kidney, you got sepsis, you got anomalies of the structure, you've got a very high load, and your anticipated operative time is more than 120, but that's not the patient we're discussing. So I think if we look at the data, we've got equivalent efficacy, we've got equal severe complication risk. We half the amount of anesthetic needed, 86 minutes in total versus 139 minutes in total. So you have to combine both operations and compare it to single setting. One admission, not two. For this patient, I think the evidence shows that if you stage this patient, you're giving them an avoidable operation. Thanks.